Thermomodalities is in chapter 5. Please have your book as you go through the lecture here and go through your notes. If you don't have it yet, at least come back and go over those areas that I'm going to point out to you in the text and in the chapter. The chapter does start off with just some basic information about heat transfer and how things, how kind of the heat moves through the body and absorbs and that kind of stuff. The absorption concept is this was in that science of modalities section last week, ultimately saying that basically as any kind of energy, and we're talking about heat, heat and cold energy, thermal energy, as any kind of energy goes into the body and penetrates into the tissue, the more absorption that happens, as it gets absorbed, it doesn't go very deep. If it doesn't get absorbed, it keeps going deep until it, keeps going through the tissue until it actually gets absorbed. So that's kind of that concept there. And the book talks about a number of different things. That table 5-1 gives you kind of an idea of some of the different types of tissue that the energy is trying to get through to where we're going. The box 5-2 is like 3 pages worth of box. It's like the biggest box box information ever. But it goes through some of the main ones. So thermomodalities are commonly referred to as conductive modalities. That means we have to have contact. So these modalities transfer their energy once they become in contact with it. So a hot pack, an ice pack, those kind of things. That's the easy way to think of it. I put this in here. Basically, anytime we come in contact with a heat source, our body becomes affected. So if we're on a really, really hot surface and we're playing soccer, then our body temperature goes up. Opposite side of that, if we sit on a cold metal bleacher for long periods of time, dude, that gets cold. Right, that transfer, and all of a sudden we get colder and colder as we go through. So that's conduction. The convection, as it moves through, we need some kind of a medium. We're talking about water or air. So when you get a cold wind versus like if you're out in the cold, if it's cold outside, you may be able to hang until that cold wind starts moving that cold air over you. When you sit in a whirlpool, if you've ever done this, you sit in there and you kind of get used to that cold water. Thank you, accommodation. But once you start that motor and the water starts moving and you move that cold water across you, it gets colder. Same thing for heat. If you sit in a hot tub, same thing on both those sides. This is fluidotherapy. We'll talk about that later. That's another form of convection or uses convection. Radiation. Most times we think of radiation from the sun, and that's what is happening. But the sun is a huge heat source, and it is radiating through some kind of medium, the air, space, our atmosphere, then our air, that kind of stuff. So that's we get radiant heat. When we're outside, we feel it. We can feel that sun beating down on us, increasing our heat. And then once we get away from that, right, we go inside or we go in the shade, that we get relief from that. So same thing with the like these little radiant heaters where the coils get hot. From a modality standpoint, it's the same process. We use infrared lights or some kind of heat source that is placed above the body, and it radiates through the medium, the air, and then our tissue itself as we go. The final one is when we talk about modalities like ultrasound, and this is diathermy that we'll talk about. Converting electricity, right? So it's converting one energy source, electricity, through this machine into sound waves and into what we're going to learn as just basically radio wave energy from electricity. All right, so then the book talks about, it goes into the cryotherapy part. And so the first one, I like these charts because I did it last time. If you know this chart, you are going to be in good shape. Where is this? This is page 111, figure 5-1. This is the stuff. I'm not going to swear on the thing. But ultimately, it kind of gives you all this stuff right here, all these, kind of, here's what cold application does. Here's the different mechanisms. Here's our clinical applications right here that we want. If you know this, you're set. In fact, I could just walk away and end this video right now and say, hey, know this, everything on there, know the pattern, because all of this stuff is going to be in the next upcoming slides, right? So why don't you just end it now, Coolum? I can't do that. So know this. This is a very good important chart. As we talk about the heat transfer part, when we put cold on there, I stole this chart again from your text. You can look at that and see in that 20 minutes of ice application what the temperature does in tissue and what that does, and then the rewarming part of that kind of stuff. Our conductive modalities are placed upon the skin, so we have some barriers or some tissue that we have to get through, and that's going to affect how deep the effects can get. And so when you look at box 5-3, it talks about adipose as our main barrier. Even we don't have to have a really large person. Everybody has adipose, and depending on where it is, like right on the tip of your elbow, there's not a lot of adipose. On your thigh, on your low back, I don't care who you are and how thin somebody is, there's a significant portion, especially 1 to 2 centimeters of adipose tissue that's there, that if we're putting cryotherapy or thermotherapy, it's got to get through there. Focus on this right here. Maybe 3 centimeters of penetration before it gets absorbed, and so that's not very deep as we start talking about it. All right, the main outcomes of what we're looking at. We want, clinical applications in that acute stage. We want to decrease cell metabolism because we know we're in an ischemic situation. We know that there's not a lot of stuff getting through. It becomes hypoxic, not a lot of oxygen, and we want to limit the amount of secondary cell death. And the only way we know how to do that right now is just decrease the demand for oxygen, so maybe those other cells that aren't damaged can hang on for a little bit longer. This also goes into we're trying to limit the formation of soft tissue edema, joint effusion. We're trying to limit those a little bit. We're not getting rid of it. Don't you wait. You listen to me right now. Focus right now on this, on my words that are coming out of my mouth. Don't you ever say that cryotherapy, ice, is going to get rid of edema or effusion. We're trying to limit it, trying to limit the formation. Once it's there, man, we got a whole nother problem of trying to get that out. But we want to try to limit it before it gets there, so it slows that formation, partly from the decrease in secondary cell death, but also from the vasoconstriction, the decreased permeability, those kind of things that go on with it. Other things, it definitely makes the area numb, so we definitely know that. And part of that numbing is from gate control. It also it also slows the conduction velocity of all of our nerves, right? So that's why it gets numb. But it also slows the conduction velocity of our A delta C fibers, which are usually slower than the sensory stuff that we have. So it does these two things to our nerve conduction of all nerves, not just pain, but of all nerves, A betas as well. So the outcome or the application sometimes of the numbing is we can allow for, once we get numb, we could do some simple exercise that may have been kind of painful before. Then we move on to the actual vascular or fluid dynamics applications or effects that cryotherapy will have, and you can see what I got listed there. It's pretty straightforward. In fact, all of this, if you look at page 116, there's a great section of that you should read through. There is where it says effects on the injury response process. Cryotherapy has a big role. A lot of people put it on in that acute injury. Some people don't like to, but if we're going to do it, why are we doing it? What's the theory behind it? Boom, 116 talks about it. Boom, these are some of the things. Why do we want to increase blood pressure and vasoconstrict? Vasoconstrict increases blood pressure. Why do we want to do that? Because we have this circulatory stasis that develops in that, so those kind of things. That's what I want you to kind of get a grasp of. Why are we doing this? If I say we're going to vasoconstrict, lower the temperature, well, what does that do? Lower temperature decrease metabolism, vasoconstrict, that kind of stuff. So that's kind of what I want you to have an idea of as we go through some of those things. If you look at page, what is that, page 118, it talks about this hunting response. We have this, the classic response or physiologic effect of cryotherapy is vasoconstriction. But there's this thing called the hunting response or cold-induced vasodilation, right? And so if you leave it on long enough, is the body going to try to rewarm itself, vasodilate, and actually do something the opposite of what we want it to do? So that's the concern. So read that as we go through. When you look at research, does the temperature of the tissues kind of starts to go up, but is the blood vessels, is that because of the blood vessels? So there's some interesting, I want you to read that box. We'll come back and talk about the efficacy or does this actually occur, and should we really be worried about it? As we go into one of the other clinical applications on the chart was spasm. Man, I got a big spasm, either heat-induced spasm or muscle injury-induced spasm. And your book talks about it on page 121, muscle spasm. Here's what it does. Ultimately, in this situation, a lot of people are comfortable with putting ice on a heat cramp. But a lot of times when you have a tight muscle that's spasmed, oh, my neck is all spasmed up. People don't want to put ice on there. They're like, no, it's cold. It's not comfortable. I don't like it. But ultimately, here's how I want you to know how cryotherapy gives us some relief, or what's the application to that. And it has to deal with, we have a shortened muscle fiber, and we just talked about the fact, there's a lot of tension. I wonder if there's a receptor somewhere in there that deals with tension and a shortened and the length of the myofibril. Yes, there is. The muscle spindles, and we know if we have a shortened, we have spasmed, a shortened myofibril, the intrafusal muscle spindle receptor is super, super short and really hypersensitized. So any movement, that thing's going to resist. It's going to cause tension. Ah! Look at that. And so that threshold for firing is low when it's super short. And so ultimately what we do with our cryotherapy, we come in here and we put, here's our little, look at that little cute muscle spindle. If we put cryotherapy on there, we're going to decrease or calm that muscle spindle down. We're going to decrease the nerve conduction velocity. We're going to lower the threshold, and we're going to make sure that that muscle spindle doesn't want to fire and produce tension or make that spasm worse at every little movement. Knock it off. Every little length change, we don't have to go crazy. So cryotherapy comes in and helps add to that component. So when we have an injury, especially injury, heat cramp, I'm going to call that an injury. When we have that, this is how cryotherapy is going to interrupt or hopefully treat the spasm that may occur after an injury situation. We're going to increase that threshold for muscle spindle activity, so it's not going to react every little length change that happens. There's definitely some pain modulation that we can occur, and then the decrease in the nerve conduction velocity of this input of this. Really, these are automatic feedback loops, right? So we don't have conscious control of this. So we just kind of calm all that stuff down and slow it down. So as a reminder, what I'm doing now, I'm coming back and I'm gonna, there's that reference to page 116 where it's talking about through the acute injury, through that healing cycle. I got some main bullet points that's a good place to come back here and make sure you know, here's the basic reasons why we're doing this. All of these on the temperature, this is from the vasoconstriction, this is from the pain modulation part. As we start talking about now application of it, right? The application, how long do we ice? Do we need to ice a low back the same amount of time as a finger? Maybe not, right? So how much, and so you start to look through here some basic guidelines, right? When we know we have a lot of adipose, we got more time. Immediate care, because we want to decrease temperature, and immediate of that after an acute injury, we want a little bit maybe longer treatment times, maybe more frequent applications. That kind of stuff. If the patient just came out of practice and we put an ice bag on them, well, and then after their 15 minutes and they go away, they're going to rewarm a lot quicker than someone who's just been sitting in their office doing videos about this stuff. So yeah, we might have some more frequent applications. So we will talk about some of these evidence, we'll talk about some of this in class when we get back together. This is also good areas that you can look when you look for your abstracts, and we'll start talking about that as well. When you look for your abstract, these are applications of how long do I ice for certain things. Those might be articles that you kind of look to see what research has done. We'll also talk about proprioception and muscle function after cryotherapy, and what a cryotherapy treatment does to both of those. Again, those are good areas of research as you start to search evidence and say, all right, how bad is it affected? How bad does cryotherapy affect proprioception and muscle function? What does that do, and why are we doing some of the things that we do? Okay, so that's part one. The cryotherapy is done, and I'll do a part two for thermotherapy.